Bonjour, I'm Professor Xavier Leleu. I'm a professor of hematology in France, CHU Poitiers. And on behalf of my co-authors, I'm happy to report the first report of the study KarMMa-2 Cohort 2B. In more details, Idecabtagene Vicleucel, ide-cel, in patients with clinical high-risk early relapse multiple myeloma without frontline autologous stem cell transplantation. I'd like to remind everyone that despite improvements in outcomes with triplet and quadruplet regimen in frontline myeloma treatment, many patients eventually relapse. And for these patients, they may have a shortened PFS, progression-free survival, and overall survival. So novel treatment, but most importantly, novel mechanisms of actions clearly are needed. The BCMA-targeted CAR T-cell therapy, ide-cel, has demonstrated deep, durable response in previous KarMMa study and has demonstrated that it was possible to significantly improve median PFS and overall response rate versus standard of care. That were the results of the KarMMa-3 registration study published now in New England Journal of Medicine. And this in triplet class exposed relapse refractory myeloma. So the KarMMa-2 multicohort phase 2 multicenter trial evaluating the efficacy and safety of ide-cel in patients with early relapse multiple myeloma characterized with functional high-risk multiple myeloma, meaning relapsing within 18 months from diagnosis. And here I'm presenting on behalf of my colleagues the efficacy and safety results for KarMMa-2 Cohort 2B, which included patients with clinical high-risk myeloma who had experienced an early relapse after frontline treatment that did not include a transplant. So KarMMa-2 Cohort 2B study design are presented here. The patients were to be relapse within 24 months relapse within 18 months from frontline, not having had a transplant. The patients were to have received upfront a PI and an IMiD. They had to have a measurable disease, and at the time of the relapse, they were to be ECOG performance 1 or below. I'm not going to talk about Cohort 2A, approximately the same profile, but patient who had a transplant upfront, and I'm not going to talk about Cohort 2C, patients that were newly diagnosed and had a poor response after transplant. So I'm focusing on Cohort 2B, 35 patients that at the time of the relapse were to be apheresed, were to receive a bridging therapy potentially, were to receive ide-cel 150 to 450 time to 6 CAR T-cell therapy, and were then followed until progression or other issues. The primary endpoint was complete response rate by investigator assessment according to IMWG criteria. Patient disposition, so 35 patients were to be recruited. In the end, 31 patients were reinfused, and for everyone, the 4 patients not reinfused were not because of failure to apherese, not because of failure to produce a CAR. It was for other reasons, patient withdrawal, physician decision, and 2 patients that did not have the inclusion-exclusion criteria. At the time of last follow-up, 30.1 month median follow-up, only 7 patients died, 3 patients withdrew, and 1 patient was stopped for physician decision. The characteristics of the 31 patients that will be studied per protocol. 9.7 were above 79, but if you sum up with the patients above 70 years old, approximately 1/3 of the patients were 70 years old or older. We will see the time from diagnosis, but it was approximately 16 months. I'd like to remind everyone that 45.2% of the patient had a high tumor burden, 12.9 an extramedullary disease, 67.7 were double-class refractory, 16.1 respectively were triple-class refractory and triple-class exposed. So clearly, this population is functional high risk by the fact that all of the patients relapsed from line 1 to line 2 within 18 months. But when looking at the details of the patients, most of them were actually fully high risk by regular definition of high risk these days. Most of the patients had a VRD or a KRD regimen upfront, but some of the patients had Dara-Lendex, some of the patients had Lendex. There was quite a number of regimens that the patient had upfront, but I want to remind everyone that whatever the regimen, all of the patients relapse within 18 months of that regimen upfront. The bridging therapy from apheresis to reinjection of the CAR, reinfusion of the CAR, and the start of the lymphodepletion right before the reinfusion of the CAR comprised treatment that the patient had upfront, but they were not refractory to KD for the vast majority of the patients, but there was a number of regimens, VRD, VD, Cyclo, K-Cyclodex, K-Revdex, Revdex. So the primary endpoint of the study was the complete response rate. The complete response rate after reinfusion of the ide-cel, best response, was 71%, ranging from 52 to 85.8. And I'd like to remind to everyone that this compares to the complete response rate that the patients had upfront. 3.2% of the patient only had a complete response upfront, while 71% had a complete response with the CAR. And so I'm not going through the details of VGPR, PR, and all types of response. I'd like to remind everyone that the time to first occurrence of a response was approximately 1 month. There's a slide with a swimming plot. That slide shows, but this has been already demonstrated with the CAR, that many of the patients improve from PR, VGPR to complete response. And that most of the patients, the vast majority of the patients who improve their response to complete response actually continue on treatment and are doing great with no relapse and no subsequent relapse post the CAR. And so more than half, 16% of the 16 patients, 51.6%, had a complete response or deeper response that is ongoing at data cutoff. We have looked at duration of response. The median duration of response is not reached. The duration of response expected, estimated at 24 months is 65.3%. And when looking at patients that are in complete response or deeper, at 24 months, it's expected at it is estimated 75.7%. We looked at the MD negativity in patients who achieve complete response or better, and we observed that the vast majority of the patients were in complete response, and that this were an MD negativity rate at 10 to -5, and this MD negativity rate improves over time. At 3 months, it was 11%, and at, let's say, 12 months, it was 19%, 24 months, 18%, 36 months, I'm saying something, I'm rephrasing here. The MD negativity rate was similar across time points. So at 3 months, 79%, at 12 months, 81%, at 24 months, 82%, and 36 months, 75%. So a high rate of MD negativity that maintains over time. The progression-free survival and overall survival median are not reached. The estimated 24 months, 63.3 for PFS, 78.9 for overall survival. So I'm going back on my slides because we have been looking more in details at patients after ide-cel reinfusion that relapsed within 12 months versus had no relapse within the first 12 months post-reinfusion, respectively 10 versus 21 patients. When we look at the characteristics of the patients, not surprisingly, we found out that 30 versus 4.8% of the patient extreme-daily disease, 70 versus 33% of the patient had a high tumor burden. And as it goes, so amongst the vast majority of the patient who relapsed within 12 months from the infusion of the CAR were characterized with ultra high risk myeloma presentation. In terms of safety profile, we had, and to make it short, we had no specific new safety profile to report. CRS in the vast majority of the patients, but only one patient had a grade 3/4 CRS. And a series of other issues, 93.5% of the patients, for example, had neutropenia, 51.6 thrombocytopenia, 61.3 anemia, and some of them with higher grades. There was very limited neurotoxicity, ICANS or IINT, any grade, only 3 patients, 9.7%, 0 patient grade superior or equal to 3. The median time to onset of the CRS was as known with ide-cel 1 day. The median time to occurrence, median time to onset of the ICANS for the 3 patients who developed an ICANS was 2 days. In terms of pharmacokinetic parameters, we were not surprised to see that patients who reached complete response or deeper response had a Cmax copy much higher than the patient who did not receive that depth of response. The AUC in terms of days copies was much greater again for the patient who had complete response, and the Tmax as well was better, higher in patient complete response and deeper. So in conclusion, there was a robust cell expansion seen in PK evaluable patients, but much robust for patient complete response and better. And so these patients can be identified early on as a potential great beneficiary of the treatment, of that treatment. At EHA, I will not be presenting the soluble BCMA clearance, but it is as known, the patient who clear BCMA, the faster, the deeper are the patient who benefit more from the ide-cel infusion. And actually, these patients maintain this deep decrease in the soluble BCMA measurement. The quality of life is as expected with most CAR-T, demonstrated again in KarMMa-2 2B cohort in patients older than usually patients that are demonstrated in clinical trials with CAR-Ts, which is a very important improvement in quality of life using the EORTC QLTC 30 and starting around M3, maintaining all over the time until last follow-up. And so this is extremely reassuring on the ability to give CAR-T and particularly ide-cel in patients more elderly. In conclusion, this analysis of the Cohort 2B KarMMa-2 trial ide-cel demonstrated frequent, deep, durable response in patients that had functionally high risk, and we have seen that more than functionally high risk, most of the patients were actually would be characterized as ultra high risk. Patients who experienced early relapse within 18 months from initiating the first-line treatment, not including a transplant. Although a high proportion of patients had high tumor burden, high risk cytogenetic, the complete response rate was at 71%, which is very reassuring on the ability of the CAR-T cells product, ide-cel, to control and rescue these patients. High rates of MD negativity were achievable were achieved, by evaluable patient with complete response or deeper. ide-cel demonstrated a manageable safety profile, and particularly only 1 second primary malignancy, above 1 disease, and no Guillain-Barré syndrome, no Parkinsonism, no grade 3-4 CRS or IINT. So quite a safety demonstrated profile, again, in patients that are elderly, more elderly, and therefore patients that we should be particularly taking care of. And so to continue my conclusion, patients who showed a steady improvement in quality of life, particularly pain and fatigue, and felt very reassured by the control of the disease. And finally, ide-cel showed, therefore, a favorable benefit-risk profile in patients with clinical high-risk myeloma who experienced an early relapse following frontline therapy, excluding transplant, highlighting the important potential for ide-cel when used in earlier lines of treatment. I want to close here, acknowledge the patient, their family. My colleagues had recruited patients in that cohort. Want to thank particularly BMS, a study supported by 2seventy bio and Celgene, and all the people who participated in collecting the data and monitoring the data. Thank you very much for your attention.